My name's Dan Chisholm. I'm the Programme Manager for Mental Health here at the WHO Regional Office for Europe in UN City. An event that we are holding for all UN City staff on site, as well as we are broadcasting this for the benefit of WHO country offices, and it's also been recorded for anyone who can't make it today. So today is World Mental Health Day, and the topic for this year's marking that event is suicide and its prevention. So we decided to organize this hour-long lunchtime event in order to talk about the problem of suicide as a public health challenge. We will also hear some personal testimonies about the impact, the effect of self-harm and suicide at the individual level. And then we'll still have some time at the end for talking about what can be done on site here, but by each of us to both support people who may be struggling, or if you yourself are struggling, where you can get help here or elsewhere. So I will pass the microphone now to Dr. Bente Mikkelsen, who's the Director of the Division of Non-Communicable Diseases and Promotion of Health over the Life Course. So Bente, over to you, please. Thank you.
Thank you, Dan. Welcome, everybody, and thank you, Dan, for setting up this very, very important meeting. So, as you all know, that we are gathered here today actually to talk about something that is very sad. It's serious, and it's also a sobering public health issue. And I think, you can already see that so many people have put the ball into this cylinder, and I think we are not at all sort of reaching out to all the people. And I have seen the faces of people sort of dropping the ball. So it is really something extremely serious. And it's not only, of course, about people themselves, the individual that are doing the suicide. It's also about their families, the society, and all of us, I would say. So even if it's visible, and of course we all agree it's dreadful, maybe even more serious is that it's also invisible. It is a lot of people that feel the stigma. If they have experienced this in their families, they don't seek advice. They seek advice too late, and we really need to do something about this. When I saw the numbers, I couldn't almost believe them, but Dan has reassured me that this is the numbers. So it is actually 140,000 deaths per year that is attributable to suicide in WHO European region. When you look into the numbers, you will see that not all countries have the same challenge, but some countries are really, really, really challenged among this. And also you can see that there are gender differences, so it is especially males. And some of you know that we have already addressed males in the European region through the male health strategy, and I think this really proves that it is needed to have a gender perspective as well. I think the other thing you need to know and hopefully remember is that this is also about protecting the next generation, because it is a rising tendency to see suicide and suicide attempts among our children and adolescents. So nearly 1 in 5 young people aged 10 to 19 years are estimated to have mental health conditions, and 15% of all deaths in these age groups are due to suicide. And in low and middle income countries in the region, suicide is number 1, and among the other countries it is number 2 in this age group. So we believe that we have some measures. We can do more to promote and prevent, but the challenge for many governments is that this is not done in the health sector alone. This is a typical multi-sectoral need for an approach. We have to line up with and join up with of course the education sector, with development sector, with the financing sector, and so on and so forth. to be able to do that. And also, of course, we need to see that governments really develop strategies. And at the moment, it's only 15 out of the 52 countries that has a strategy. So we think that sort of celebrating this day, even if it is a sad message, is a way for us to bring this discussion out of the shadows, and also to improve the awareness, and also to use the sort of the slogan of the day to focus for 40 seconds of action, and together see what we can do for suicide prevention. Thank you, Dan. Over to you.
Thank you very much, Bente, for your opening words. So I'll just say a bit more about the campaign. Sorry, that's better. I'll just continue to say something about the campaign and just build a bit on what Bente was saying before we move to our other members of our panel. So I've got a couple of slides which I can just about see. I can't actually read them. I'll stand up. The 40 seconds. It's a powerful statistic. So every 40 seconds, someone in the world loses their life to suicide. So that's 3 every 2 minutes. That's 90 per hour. That's 800,000 per year in the world, out of which about 140,000 are in this region in Europe. So it's a huge number. And for every completed suicide, we know that there are at least 20 attempted suicides. So these are often more hidden. And that's a bit reflected in the cylinder. You will see that there is nowhere near 20 times more white bulls as there are red bulls. We often don't know about the attempted suicides that take place. So this was one of the messages I think that comes out from this little mini campaign that we have done this week with the help of the team, and Tina's around somewhere who masterminded this fantastic idea of putting this cylinder in just to denote every person that people working here know who have either completed or attempted suicide. It really helps to personalize the issue and make us realize that this is an issue that affects not just 1 or 2 people as a rare event that happens to other people. No, it affects a lot of people. I mean, there's at least 1,000 bulls in there. And this is over a course of 4 days. And we don't know how many people participated in this actively. And in a way, that doesn't matter. What matters is that there are 1,000 bulls in there for what is a small community of people working. So this is part of the need is to raise awareness about the issue. So Bente mentioned something about the numbers. I don't know if you can see these too well, but basically 2 points here that Europe as a region, compared to some of the other regions of WHO, has one of the highest rates in the world. Particularly, you can see this yellow spike, which is the male rate of suicide in the European region. In other regions of the world, it's actually more balanced, between males and females, but it's very, very high amongst males in this region. On the right-hand side, you see all of the countries of this region sort of ranked by the rate of suicide. The red in the middle is for both sexes, the green is the female rate, and the blue is the male rate. So you can see, again, very visibly the difference between males and females, and particular attention to the almost exponential rate of suicide amongst males at the top part of that graph, which is countries including Lithuania, Belarus, Russian Federation, Ukraine, Latvia, and 1 or 2 others. And they're part of what are driving some of these very high rates in the region. So the 40 seconds of action that we're all encouraging all of you to participate in today is around the improving the awareness about the issue, the gravity of the issue, and understanding more about what can actually be done, and also by participating in this help to address the stigma around the issue. And some examples on the right. Doesn't matter whether you are the UN Secretary General, who we're hoping will participate in about an hour's time if we can put ourselves between him and the rest of the building, or you're an employer, or just a colleague or a friend or a family member who could help someone in need. So I think one of the things we want to stress is that suicides are preventable. They're not an accident waiting to happen. They're all preventable. So that means that we really need to understand more about the risk factors behind that. It's an extraordinarily complicated set of risk factors around individual characteristics, about social determinants of health, as well as maybe broader environmental or macro kind of issues. Some of these are mentioned here, so you can think of it more as these are particular groups of individuals, for example, who have had previous problems with mental health issues, might be suffering from chronic pain, or might have a substance use disorder. People who are exposed to conflict, violence, are at increased risk, and also people who are often vulnerable to discrimination, including refugees and migrants. So this is the WHO's package of interventions for suicide prevention. It's called Live Life, and it contains a number of kind of active elements, which would be including the reducing the access to the means of self-harm or suicide. So in the USA, that might mean firearms in particular. In many parts of Asia, the main cause of suicide is through ingested poisonings, pesticide poisoning. So it would be reducing access to highly hazardous pesticides. Another very important part is the role played by media in responsible reporting as opposed to sensationalist reporting of suicides, because we know that after a suicide of a celebrity, for example, this can often lead to a spike of other suicides. Copycats are called suicides. Then there's the young. Particularly in this region, again, we see over in the world, we see some decline in the overall rate of suicide, but in places like Europe, we see an increase in the rate of suicide amongst young people, which is a huge concern. And so building up the life skills, the resilience, the coping strategies, or coping skills of young people is extremely important as a preventive mechanism. And finally, of course, we need better services, mental health services. So people, when they go to a GP or a counsellor, there are people who know how to respond effectively. And then the final point I'll just say here, these are some of the things that need to happen, both at a national level. It's obviously important to have as Bente was mentioning, very few countries have a dedicated sort of plan or strategy about how to handle this. Like in so many other parts of health, there's a huge requirement to work together between different sectors. So education, I was talking about the young, about the social services and other welfare services, as well as the healthcare sector. Okay, so I think at this point I will go back to my moderator's chair and invite Louise, who's working for One of Us, and you could perhaps just say for a moment say what One of Us does before telling us about your lived experience with this issue. Thank you.
Thank you. Can I borrow this? Thank you. Okay. Yes, and thank you for the opportunity to be here today. It's a very important topic, and it's very important that we talk about this. My name is Louise. I'm an ambassador for One of Us, a Danish anti-stigma campaign, which works against stigma and making more awareness about mental illness, and that we need to talk more about it, and breaking taboo and silence about mental illness. I'm here today to tell you my personal story about my mother and her experiences with suicide attempts and how I experienced those attempts. As I said, my name is Louise, and I'm 27 years old. I'm a trained nurse. I worked a few years at a mental health ward for children and adolescents. Today I'm studying for a master's in psychology and health promotion and health strategies, and I'm ambassador for One of Us, where I'm also a trainee in connection to my education. First I want to tell you a little bit about my mom. She is diagnosed with schizoaffective disorder, which means that she have episodes with both psychotic and depressive episodes in her life. And she has been ill for most of my life, as I remember. So when I look back at my childhood and in my youth, I remember her as very isolated. She couldn't participate in my life like a normal mom. She couldn't go to parent meetings or go shopping with me, go to theme parks, all those things that a normal mom would do, because there were too many people and too much noise, and she couldn't deal with that. I remember her as very angry, mostly because me and my little sister were making too much noise, or we somehow disturbed her. She was very sad. I don't know why she was sad. She always just looked very sad and cried a lot. But mostly she was just tired. She slept all day long, or laid in her bed all day. And when she was most affected by her mental illness, she got admitted to a mental health ward several times, mostly because that she had thoughts about taking her own life when she was depressed or psychotic. And I want to tell you about 2 episodes where she had tried to take her own life, and how I experienced those episodes. The first one I've chosen is when I was about 14 years old. I came home. I have been in a sleepover with my friends, and I came home, and my mom was home alone, and she was sleeping, and nothing usual about that. She always did that, so I just decided that I wanted to clean up my room, and decided to move a big bookcase I had. And when the bookcase was in the middle of the room, I realized that I couldn't move it alone, so I tried to wake up my mom so that she could help me. But I couldn't wake her up. And I didn't think about that. I just thought she was sleeping very deep. She did that mostly because of her medicine. But this time I got so frustrated that she just couldn't wake up and help me for a moment, and just be a normal mom. I got so angry and frustrated. I was just sitting on the bed and cried while she was sleeping. And while I sat here on the bed, my stepdad called home and asked how my mother was. And I said that she was asleep, but I couldn't wake her up. I didn't realize at that moment that something was wrong. But he knew then that something was wrong, and he came home and couldn't wake her up either, and called an ambulance. And a bunch of doctors came and examined her and took her in the ambulance into the hospital. And that moment I didn't really know what was going on and what was wrong with her. But we didn't talk about it afterwards. There was a lot of silence that day. I stayed home with my stepdad and my little sister. My little sister is 6 years younger than me. We hugged that day and we got to bed, but we didn't talk about what happened. I think that it was first the next day I realized that she had taken an overdose of her medicine, and afterwards she got admitted to a mental health ward. The second episode was a few years later when I was around 16 years old. And my mom has been stable for a while and hasn't been depressed or psychotic for a period. And it was a beautiful day in the fall, like today. And the sun was rising, and we lived near a lake and a big forest. And it was an obvious day to go for a walk in the nature. And my mom wanted to go for a walk. And nothing strange about that, but the only problem was that she had no intention of returning home. After she has been gone for a while, me and my sister were a little worried and also a little worried why she hasn't returned yet. So we took our bicycles and took a ride around in the area to look for her, but we couldn't find her anywhere. And we went back home and told my stepdad, my sister's dad, that we couldn't find her anywhere. And he got worried too and tried to call her, but she didn't answer her phone. He tried to call friends and family, but nobody had seen her. We took the car and drove around in the area again and looked for her, but couldn't find her. He called the police, but they couldn't help us because she hadn't been gone for so long, so they couldn't put out a missing person report. But they would try to track her down on her phone, but they could only do that if she answered her phone when we called her. But she didn't. And it was getting darker and colder, and we just kept looking. And when it was completely dark, and she still hasn't returned, we was really worried. And the only thing we could do was to take some warm clothes on and take some flashlights, and then we went to the forest. And the forest was completely dark. And we walked out there, me, my sister, and my stepdad, and looking for her. And at that moment, I was sure that we would find her dead. I remember that we came to the beach in the forest, and my stepdad said that me and my sister have to wait while he was looking at the water. And that moment, I was sure that he would find her dead in the water. But he didn't, and we couldn't find her in the forest. It was impossible. So we went back, and my grandparents came home to us, while my stepdad was out, keep looking for her. And while we were at home, me and my sister got a text message from my mom. She wrote something like that she loved us and that we have to take care of ourselves and each other. And this was clearly a goodbye message. So we called the police again, and they would send out some dogs and policemen in the forest to look for her. And in this moment, I was sure that this was it. Now I didn't have a mom anymore. But fortunately, our mom suddenly answered her phone while we called her, and the police could track her down and find her. Actually, my stepdad took out and found her in the forest. She was sitting cold and distant, and he brought her home. And she walked to the toilet, and I followed her, and I asked her, what did you do in the forest? And she just shook her head and said nothing. And then she went to bed, and the same thing could we do. And then we could just go to school and work the next day like nothing happened. I couldn't. I stayed home that day to watch my mom. But as you can hear, there was a lot of silence, and when these episodes happened, we never talked about what happened, and we still hasn't talked about it as a family. I have talked with my mom about them. She can't remember them, but she has told me that it wasn't her who wanted to die. It was because of voices in her head that told her to take her own life. But at that time, I didn't know that. I just thought that she wanted to leave us, that she didn't want to be our mom anymore, or that she didn't love us. But because that we never talked about this, I got a depression when I was 20 years old. I needed to deal with all these emotions and feelings that I've had in connection to my mother's illness, in connection to these episodes. I got a lot of therapy and some antidepressant medication, and after 6 months I was okay again. But it is still difficult to think about these episodes, and my sister is still struggling today, and our family still needs to be more open and talk about this, but it is difficult. Today, my mom is well. She has partly recovered from her mental illness. She only has a few symptoms, but she can control them. And today she has the ability to be a caring mom and do all the normal things a mom would do that she couldn't do when I was a child. These pictures is my stepdad and my little sister and my mom. You can see. And I'm telling my story as one of us ambassador to encourage others to be more open and to talk about things that are difficult and not make any silence and taboo about mental illness, because it's only getting worse when we don't talk about it. Yeah.
Thank you very much. Thank you very much, Louise, for your personal story. It takes a lot of courage and brave. I was saying what amount of courage and bravery it takes to actually talk about these issues, but what was striking is that not only the terrible consequences on you and other family members of such acts of self-harm over a long period of time, the impact on others, but the fact that as a family you weren't able to talk about it. And so I think that's precisely the kind of message we want to sort of convey, as you did at the end, that it's okay to talk. And it's also okay to be not okay, and therefore to talk about not being okay. So this was really very nice example of that. Thank you for your time, and I think we now pass to Julie, who will talk a bit about the work that she and others do as from the Lifeline NGO. Thank you.
Thank you. Let me just move on. My name is Julie. I work at the Danish Lifeline here in Copenhagen. We are an anonymous counseling service. We have around 200 volunteers who work each day, each night. We are open until 4 in the morning with responding to calls, emails, chats with people who have suicidal ideation. Not necessarily all of them have that, but as a preventive measure, we speak to everyone who contacts us. We respond to about 14,000 people each year, so that's quite a lot. I am a psychologist, and my responsibility is to train our volunteers, to supervise them, and to come out and teach the whole world about suicide prevention, as I'm doing here today. And I only have 10 minutes, and I'm completely stressed about it because it's a huge topic. So if I speak too fast, it's because I want to tell you everything I know in 10 minutes, and I know that's impossible, but I'll try to give the key points at least. So please forgive me if I speak too fast. I want to talk about some of the things that are really important when we talk about suicide. These are the myths about suicide, because all these myths work as a, let's say, a measure that doesn't make us prevent suicide, because we don't do what is necessary because we are afraid to do it. So one of them is that there's a huge myth that suicide only affects individuals with a mental health condition, like Louise's mother, which is far from the truth. Everyone can become suicidal. Of course, if you have a mental illness, many of your symptoms will be derived from suicidal symptoms, and you will have a deep hopelessness concerning, will I ever become well again? But everyone confronted with crisis, life crisis, divorce, physical illness, anything that sort of makes your life unstable can become suicidal. It's not just for the people who suffer from mental illness. Next, talking about suicide will lead to and encourage suicide. This is one of, I usually say, one of the most dangerous myths that exists. And it exists in everyone, all of us, in healthcare professionals. I teach a lot of nurses, doctors, psychologists, and everyone says, well, if I talk about suicide, if I ask them about suicide, won't I just give them the good idea that suicide is an option for them? And nothing could be far from the truth, far from the truth. You cannot inject, or anything the like other people's suicidal thoughts. It comes because they are in a place where they cannot come out of, and that makes them become suicidal. Not you. We can't give each other any thoughts, so why do we believe that we can give each other suicidal thoughts? It's a mystery to me. And this is a dangerous one because it prevents healthcare professionals, all of us, in asking about it. And that's one of the reasons why we don't talk about it. We are so afraid that we will sort of do more harm. And actually it's the opposite. Talking about it makes the stigma lessen. It makes it easier to talk about. It makes it easier to seek help. And we know from research and from our experience at the Danish Lifeline that talking about it actually decreases the risk. We can see that when people contact us, a lot of them are in what we consider high risk. They have clear plans for their suicide, and we are able a lot of times to talk them down the risk so that we end somewhere else than when we start. So talking about it helps. The next myth is that suicide mostly happens suddenly, without warning. We all know the notion that I didn't see it coming. I never thought that this would actually be something that he or she would do. How can it be? We think we didn't see the warning signs, but they are there. We know that around 60 to 80% of all suicidals have talked about it, shown it, directly or indirectly. We're just not good enough to see it. It can be said, I think we have an urge to comfort. So if someone you know tells you, I feel really bad, I don't feel like being here anymore, our first urge is to sort of, this will be better. Don't feel that way. This will be better. So we do not acknowledge the deep hopelessness that this person feels. And that makes them feel even more suicidal because I am now saying it and it's just comforted away. So we need to be able to dare to ask. So if you are saying that you don't want to live anymore, are you actually thinking about suicide? Do you have any plans? In order for it to sort of lessen from the heart, so to say. We can see that it's not only what people say, they can say it indirectly or directly. They can say, I want to kill myself, which is a very direct statement. It can also be, I just want to crawl into my bed and not get up every morning. That's also a suicidal message. It can also be in the observed behavior. If people suddenly withdraw from everything, if they've been very social and suddenly withdraw, isolate themselves, it can be a sign. I'm not saying that everyone who is withdrawing from social events is suicidal, but it makes our alarm clocks buzz. If they suddenly do not take care of themselves, they do not tend to their own personal hygiene, this can also be a warning sign. If they become promiscuous, do a lot of things that they would never have done before, a very strict change in behavior is also an indication that something is wrong. And people always ask me, what do you do when you see that, when you hear it or see something? How do you sort of attack that? I will say, why don't you ask? I have noticed that you are withdrawing from everything. Is it because you don't feel very well? No, I don't feel very well. Okay. Are you thinking about suicide? And when I teach about this, everyone says, I'm not very comfortable. That would be a very strong word. And I don't see it. It's because I've been working with this for ages. I know why it's difficult. But it's because that we are afraid of listening to the answer. We're afraid of listening to what happens if they actually say, yes, I am considering suicide. What will happen to us then? We're afraid to ask and we're afraid to listen. But remember that listening and talking about it actually helps. The last myth, there are a lot of myths, I've only chosen 4 of them, but the last one is that most suicides happen around the winter holiday season. We get a lot of questions concerning that maybe during the winter Christmas holiday, don't people kill themselves a lot there? No, they kill themselves in the springtime. Springtime, because if you've had a depression and you're waiting for it to become relieved during spring and it doesn't, it's still there. All hope is gone. That's when you do it. Not when everyone else is together on Christmas Eve. It's when you had the hope and that hope is taken away from you. Or as other people say, if you go through the time period of getting relieved, more relieved, you actually get the energy to do it. So when you're deep down in your depression, you don't have the energy to do it. But when it sort of is relieved, you have the energy to do it. So that's why springtime is very important. I know, and I will just, you have said most of the things. I have the card there from your intern, and I think I have, it's not the yellow one yet, is it? No, so I have some time. What I want to talk about, you were talking about the risk factors, but one of the things I think is important to highlight is the first one, a previous suicide attempt. Because if you have once crossed that line, the risk that you will do it again is higher. So if you know that someone you know has tried once, be aware when they suddenly fall down again, because there is a higher risk that if you have crossed the line, if you have forced your body to come there where it can stand the pain or stand the drowning or whatever, you are able to do it again. And one of the other things that, listening to your story, Louise is actually, if she hadn't talked about it, in a high risk as well. Being related, bereaved to someone with suicide increases the risk. We call it suicidal transmission. It's not that suicide is contagious, but it is because Louise's mother is teaching her a coping strategy that if she doesn't talk about it, which is wonderful that she has, actually makes it a coping strategy for her as well. So be aware of families with suicide. Yeah. And I will go very briefly through. There's a lot of psychological pain, and I think I have touched upon it, but the feeling of hopelessness, the feeling that you are entrapped, that there will be no other way out, is something that we encounter all the time at the Lifeline. They do not think that there is any way out, and it's our job to try and give them a way out that is not suicide. We have talked about very briefly, from my point of view, what you didn't come across is the restriction of lethal weapons, of lethal means. We do a lot of taking away methods from the people who contact us. If they are sitting with their pills in front of them, we tell them to flush it out the toilet. If they are sitting with a rope, we tell them to put that rope in a drawer or somewhere else where they can't think about it. When you see at train stations, there will be fences. Golden Gate Bridge put up a lot of fences to inhibit them using the method that they had chosen. Method restriction is one of the most preventive measures of all time. So taking away their measure, their method, is really, really important. So keeping them safe. You can see, this is what you'd said as well, all these treatment of depression and chain of care.
Almost out of time, but time for 1 or 2 questions anyone might have from the audience this afternoon. Any questions, please? Take one of the mics.
Thank you. At what time, considering then we may know someone who is at risk, but they are adults. And at which point can we suggest to seek help, and what to do if they refuse to seek help because they are adults? So we can't bring them anywhere.
Julia?
That is one of the most difficult things, to persuade others to get help. But by at least being there for them and letting them know that you at least are not afraid of asking, makes it easier for them to maybe understand that they need help. But you should try to refer them if they need anonymous counseling. It would be like a lifeline in either country. Tell them that there is always another way. They're just not able to see it right now, but that you can be the bearer of hope for them. You ask me when to do something, and I think that the closer in plan people are, if they have what we call set a method, set a time, set a place. Yeah, exactly. Then it's dangerous. The closer they are to their plan, and if it's within the next 48 hours, we call it acute, and we need to do something here and now. But many people have suicidal thoughts without any plans, and they are afraid that if they say it, that you will actually contact the police or the emergency department. And that's not where they are. They just want to talk. They just want to be talked to and be held and be relieved from their stress. But the minute that you feel that their plans are set and that it's within a short time frame, then you need to act. The law says so anyway. So you need to follow them to the psychiatric ward if you can do that, or call the police or someone who can take care of them. But as a close related person to someone who is suicidal, you also need to talk about it with someone else. There is, in Denmark at least, an organization who takes care of related people. It's called NEFOS, NEFOS. They help a lot of people who are in a situation that they don't know how to help, what to do, how can I do it. So try also to find organizations that will take care of you as the relation next to. Did that answer your question? Mm?
That's great. Okay, unless there's any other quick question, one from the back here. Yep, is it from a country office? If you can project it quickly.
There's a question, an interesting one from one of our outposted offices, and the question is, what would you say one should do when someone refuses life-saving treatment, if that counts as suicide?
In the end, it is the individual's own responsibility. You can only help this far. You cannot take over their life. But I would take any measure to try to convince them that they need help, that help is there, that I will be there for them, that I will listen to them, and that I will help them get help. And that I want them to stay alive because they are a valid person in my life. But at the end of the day, you cannot force people to get help if they don't want to. And you can't get them committed to a psychiatric board unless they are in danger for themselves or for others. So that is really a distinction that is very difficult because, well, if you're at risk at suicide, aren't you at a risk of yourself? But I'm afraid to say that many psychiatric wards won't admit people unless they actually have self-harmed. So it's not just the ideation that makes them be admitted to a psychiatric ward. And that is something that maybe on a political level would be needed to be addressed.
Okay, so I think we need to draw things to a close. We've ranged from everything from suicide as a global public health challenge and a SDG indicator down to extremely personal stories of the impact of self-harm and suicide at the individual, family, community level. And we've also talked a bit about the things that we can all do and learn, and how to be better listeners. And we had some very good practical tips and suggestions about that. So I think it's been a great session. So I'd like to very much thank all of the panelists and the colleagues here for their time, and to you for participating in the session. And if you want to share this with other friends, colleagues, please feel free to do so.